Good morning.
I invite us to sing the Mashiach Nigun, knowing that we are here today to bring some sense of justice and freedom to ourselves. So it goes like this. Yai, lai, yai, lai, lai, yai, lai, lai. Sing it with me. Lai, 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 yai, yai, lai, lai, yai, yai, lai, lai, yai, lai, yai, lai, lai. Yai, lai, lai, yai, lai, 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 lai. Yai, ya, la, 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 ya, la, 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 la. Lie, 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 lie. This is an opportunity to look around the room as well and see other people singing. Lie, 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 lie. Lie, 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 lie. Lie, 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 lie. I'll pass this back to Rivkah to continue the welcoming.
So much, Toby. That was perfect. So thank you all for coming on a Sunday morning, taking time out for this important but somewhat daunting topic. So give yourself a pat on the back for overcoming any pause you might have had, and congratulate yourself on taking the step. It's a real gift to yourself and a gift to family and friends to have thought about end of life issues ahead of time. I want to particularly thank Toby Hoffman, who is not only doing some of the introduction portion, but also will be handling the Q&S today, and Sherry Cohen, who, as I mentioned before, is doing the tech, and especially welcoming Rabbi David Teutsch, who has agreed to lend his expertise to this program and around whom this program is really built. David is not only all the things on his resume, which is represented in your advanced materials packet, but David spends a good deal of his time when he's not long distance biking. He is out doing consultations with all manner of rabbinical organizations, medical organizations, individual families around serious and difficult end-of-life issues, as well as other ethical concerns. So it is a really profound privilege to be able to hear him on these topics. The plan for the next few hours, we've divided this program to two halves. The first half, we're going to be looking at general ethical concerns around end-of-life planning. We're going to talk a little bit about advanced planning and then focus in on palliative care and hospice. We will take a 5-minute bio break. And then afterwards, we're going to focus in on medical aid in dying, what it is, and then the ethical issues around it. We'll watch a very short film clip, and then we'll have a second Q&A. I do want to suggest that you have your advanced materials available to you in case you need to refer to them. And I want to encourage you to note down any questions you may have during the program, because there'll be a point where we'll ask you to put those questions into the chat. In general, I need to ask that you be patient with us. We're not experts at large Zoom meetings trying to do a lot of interaction, so please have patience. Please also take care of yourself. If there's at any point you need to get up, leave for any reason, please do. And just generally hope you get the most out of this session. And now I'll pass it back to Toby to get us ready to go into the session itself. Thank you.
Welcome. My role here is to get us here even more I see people really ready, which is wonderful. I want to welcome you to this time of self-care. We're told to have self-care, and this is one of those times. I imagine we're going to be absorbing a great deal of information. So take a moment and figure out think about what you're curious about. What might be some of your anxieties about this material? What are your questions already about this topic? And then let's start with a deep breath. A nice inhale and exhale to be fully here. For gratitude, gratitude for making this decision to be here. Gratitude for joining in community to learn this information. Gratitude for yourself. Gratitude for the family members that you will be gifting this to. So, another breath in and out. And now put on your curiosity kippah. I will turn it over to Rivkah.
Thank you, Toby. Really appreciate that. Perfect. So we want to start with a kind of interactive little exercise, and it's going to take a little sort of coordination among us all. So the question that we would like to get answers to out in our common space is, what are your concerns about the dying process? And in order to answer that, what I'd like you to do is spend a few moments thinking about what those concerns may be. You may have just a few, you may have many. And then when you're ready to share them, raise your electronic hand, which should be an option at the bottom of your screen. And if anyone who hears you agrees, shares that concern, what I'd like you to do is use the reactions, in particular the thumbs up symbol, like that. That means we know that it's a common concern, and you don't have to come on and say ditto, as often is the case. Toby, did you want to start?
Not having enough money.
Gabriella.
I'm very concerned that my choices will be painful to my loved ones. They wouldn't be the same choices they would make, and that will cause a lot of anguish at a time that's already so filled with pain. And I don't want to cause more. It's something that I think about a lot. DeBarty.
Thank you. Rose, please unmute.
Being alone with no one to do the advocacy for me at a time when my brain and my body cannot advocate for myself.
Jane.
I share Gabriella's concern. I have a sister who's a Lubavitcher. She became more religious in her 20s. And so end-of-life decisions are, in my case, would be very different from the ones she or her family members would make. Also, my husband and I have a house full of clutter and have struggled for quite a while figuring out how to get rid of it so they don't become a burden to other people. And I've also been a witness to people who in the final stages of their life have end of life measures that I don't want ever to have done to me. So it's confusing. I've had an uncle who, for example, lapsed into a coma after a catastrophic event, and his daughter actually was in a coma for 6 months. So there's all these things that aren't so easy to solve when they actually come down to real life situations. You can have a plan in your advance directive, and then life comes at you with something that's a curveball.
Jane, thank you. And I'll call one more person, Ellen.
Uncontrolled pain.
Oh, thank you. All right. Thank you for all those spoken and unspoken concerns that you may have. I want to now turn the mic over to David, who is going to begin to address some of those concerns with a discussion about ethical principles and choices when approaching death.
One of the things that should be said up front is that the Jewish principles around end-of-life care and death stemmed from a time when very little intervention was possible because the state of medical care was so primitive. Perhaps the most famous dictum is that saving a life is so important that it trumps Shabbat observance. The mitzvah that our tradition puts forward is the obligation to heal, and that obligation is on everyone, not only about themselves, but about everyone else. And our tradition sees that as an obligation that can also be placed on the community. And it's an interesting thing because it's questionable as to what it means to heal. In earlier times, it meant to do everything you could to save a life. In our time, healing may just mean palliative care, that is to say, pain management. The guiding underlying values in making these decisions are, first of all, what is letovato or letovata, what is in the best interest of the individual who is ill. What is in that person's best interest is not necessarily to engage in the very most life-saving measures possible. It may be at some point to switch to simple palliative care, and it may mean at some point the withdrawal of all medical intervention. These issues arise around a few major, very common medical interventions now. One that's worth thinking about is CPR. CPR makes an enormous amount of good sense when someone has had an accident, for example, electrocution, or a car accident, and the chances are very good that once they can be getting the right kind of medical care, they can be restored to full living. CPR does not make sense when you're talking about a 90-year-old frail person who's had a heart attack, because CPR on someone that age virtually inevitably ends up with broken ribs that don't heal right and are therefore constantly painful. And CPR at that stage in life, if it's successful, which it's usually not, results in a life of pain, often excruciating pain, until the end finally comes. So CPR should only be administered when that makes sense. A second major issue is respirators. Respirators, as you probably know, involve a machine that breathes for you. Because that feels so weird and uncomfortable, respirator use is almost always accompanied by sedation. Respirators are enormously helpful when someone is fighting an advanced infection, for example. They make much less sense in the case of advanced cancer, because at that stage, you're prolonging someone's life in an unconscious stage, often with pain, and no possible good outcome. A third major category is the feeding tube. There are several varieties of feeding tube. In a short-run emergency, the feeding tube is usually inserted down the throat. It's also possible to insert a feeding tube through an incision in the stomach area. The purpose of a feeding tube is to provide nutrition for someone who can't eat for themselves. Again, this may make a great deal of sense as a temporary measure in the case of someone who is unconscious but is likely to return to full use of their mental and physical capacities. It does not make sense when it's sustaining a life that otherwise cannot return to normal brain activity and some level of physical ability. One of the situations that often arises is insertion of a feeding tube because they think that someone will revive, and then over time it becomes clear that the person will not return to full consciousness. The question then is, can the feeding tube be removed? And the answer is yes, by all means. It's no more unethical to remove a feeding tube than it is to refuse to insert one. And the guiding principle has to be letovato, what is in the patient's best interest. One of the aspects of best interest is kavod, dignity, sometimes in other contexts translated as honor or glory or respect. One of the ways that I've seen this become a primary issue is in the case of ALS, Lou Gehrig's disease, where the person becomes unable to move at all, can't go to the bathroom by themselves, can't clean themselves, eventually can't talk. And many ALS patients experience this incapacity as a loss of dignity. It makes no sense to preserve a life where the person would much rather retain their dignity than go through the process of the advanced stages of ALS. So the concept of dignity plays an important role in thinking about what's in the best interest of the patient. However, what's in the best interest will vary patient to patient because they have differing ideas about how important life is, how well they can sustain pain, what's most important. Somebody, in my experience, said, as long as I can see my grandchildren, I can endure any amount of pain. Other people say it's time already. One way to end a life is called VSED, which involves the voluntary stopping of eating. That's possible to do. It is not considered suicide, but it is one of the more painful ways to die. And you can read about that in the material that's included in the bibliography. So removing life supports is also an option. It is not considered suicide by Jewish tradition. But as you can read in the quite extensive article I wrote about assisted death, there are certainly ways within classical Jewish tradition to justify assisted death. So there's a wide range of approaches within Jewish tradition, but the key thing to hold on to is that concept of how does the patient, him or herself, define what's in their best interest. Back to you, Rivkah.
Now it's my turn to talk a little bit about how do you let those wishes be known, and how do you increase the chances that your wishes, your directions will actually be followed when the time comes. Whether you want to maximize medical interventions or minimize them, or something in between. Again, your wishes, your choice. So most of us have encountered information about advance directives or living wills. There are links to the forms in your advanced materials. The advance directive that's given there is the Pennsylvania official form. And we also provide a link to a form that's become more and more popular called 5 Wishes, which expands on the basics of the Pennsylvania official form. It also includes, or attached to the advance directive, is a form in which you designate your power of attorney or power of attorneys. And in Pennsylvania, it's important that these forms be witnessed by at least 2 witnesses. And it's highly recommended, although not required, that the forms be notarized. That will increase the chance that any contest anyone raises about your wishes will be decided in favor of what is on the forms. But that said, probably the most important thing you can do is actually to write a supplementary letter that lays out what your concerns are, what your tipping points would be, the genug, the I've had enough moments. And we've also included in the packet a sample letter, and it's really only that. It's a sample letter by Sandra Butler, based on a letter that was circulating in her community, in which she lays out what her concerns are, what her values are, and what her tipping points would be. And I commend that letter to you because it is really powerful and very clear, and I think would provide you with a good framework for creating your own. In general, I suggest in the glossary, the very first entry is advanced planning, and that you take a look at the links provided there to some websites that do an excellent job leading you through the process of identifying your concerns and values and how to get them down on paper and how to discuss them with your medical team, with your family, friends, whoever else will be part of your caretaking team. Finally, I do want to talk a little bit about one form that often gets omitted and is often misunderstood, and that is the POLST form. POLST is an abbreviation for Pennsylvania Orders for Life-Sustaining Treatment. In other states, it may be called portable orders or MOLST for medical orders. This is a one-page form, usually printed on bright neon-colored paper, that is created between you and your doctor. It is only for use if you are or become frail or have a chronic life-threatening disease. It is not for the worried well. The POLST form is a standardized document that helps doctors, nurses, healthcare facilities, and probably most importantly, emergency personnel honor the patient's wishes regarding life-sustaining treatments in emergency situations. It affords the option of a DNR, a do not resuscitate order, and a DNT, a do not transport order. And it's the only document, and I have to really emphasize this, it's the only document that emergency personnel will obey. They will not pay attention to your advance directive because it's not a doctor's order. The POLST form is completed by a doctor or other healthcare provider only after a discussion of end-of-life choices with the patient or their medical POA if the patient is not able. The form is then signed by the healthcare provider and becomes that medical order that is understood and followed by other healthcare professionals. It's printed in Pennsylvania on neon pink cardstock and posted in a prominent place in one's home or bedroom. Sometimes you see these attached to your refrigerator with magnets. In PA, there's also a wallet card that patients can carry with them. And in other states, there are things like medical alert bracelets and the like. So that's a quick overview of what you can do to identify your wishes, make your wishes known, and to help ensure that they're followed. Back to you, David.
And just to tag on to the end of that, you don't necessarily have to have a relative hold your durable power of attorney for healthcare. That can be anyone that you trust who's willing to take on the responsibility. But a warning about that, you need to sit with that person and go through your advance directive so they really understand it. I had the experience recently of getting a call from the hospital in the middle of the night because someone had listed me as their DPAC and I had never seen an advance directive from them. So I had to replace their preferences with my best judgment. So don't let that happen to you. Make sure that you've picked someone you trust for the DPAC, and then make sure you sit down with them and go through so they really understand your choices and that they consent to follow them, because you don't want them to assert their preferences over yours.
David, what's the DPAC stand for again, please?
Durable power of attorney for healthcare. It's a pretty standard form, and you should really have one. And your DPAC should not be one of the signatures on your advance directive, nor on the form selecting your DPAC. Just for legal purposes, it needs to be clear, particularly if you're worried that a relative might try to overrule your preferences. I want to move on and talk about palliative care for a few minutes. Palliative care literally just means pain-removing care. And palliative care can occur anytime, any place. If you break a leg and you go to the hospital and they administer morphine, that's a form of palliative care. Palliative care, however, becomes much more important when you have an ongoing illness, such as cancer, or when you have pain associated with the end of life. Palliative care should always accompany cancer treatment or any other form of painful situation. And the best palliative care is administered by palliative care physician specialists. So if you're in a situation where whatever is wrong with you is not providing enough pain relief, you should make sure that you get help from a palliative care specialist, not just the surgeon or cancer specialist with whom you're otherwise dealing. Palliative care works really well as part of a team approach. Palliative care can also be in forms that are not necessarily medical. At Jefferson Hospital, for example, they very often offer acupuncture as a form of pain relief for people who are being treated for cancer. Massage and physical therapy can also be forms of palliative care. So palliative care should be understood really broadly, and it should be sought out anytime you have significant pain or itch that doesn't respond to the kinds of easy solutions that most minor pains do. The difference between palliative care and hospice is that hospice is generally reserved for managing pain and other issues toward the end of life. Hospice is generally not invoked until intervention medical care is suspended, whereas palliative care can be used right alongside other medical interventions. The form of palliative care known as hospice, it usually comes in only at the end once major medical interventions no longer seem advisable. And there are lots of variations of hospice care available, several different varieties. One form becomes available in a hospital, and that form often is relatively short term because most hospitals, once you're on hospice, don't want to keep you in the hospital. They want to transfer you elsewhere. Now, that might be to your home. I've known people who were on home hospice for 6 months, which is the normal limit for hospice, and then had their hospice renewed. Hospice care is covered by Medicare as well as Medicaid. You can be on hospice for longer than the official 6 months. Hospice at home only works if you've got the support at home to help, because hospice involves visits. It doesn't involve assigning a person to be there 24/7. The commonest place where you find hospice is in nursing homes or in hospice facilities that are set up just to provide hospice. Both of those are very common in the greater Philadelphia area, as well as in almost every urban area in the United States. Less frequently in very small towns where nursing facilities are usually where hospice is administered. Which location for hospice makes the most sense is an individual choice based on what other kinds of care are available in your area and also on personal preference. But really, it's important to hang on to the fact that palliative care can be administered any time that there is significant pain or itch. You don't need to go on hospice in order to get palliative care. Rick, back to you.
Thank you. I am going to just spend a few minutes elaborating on VSED, the voluntary stopping of eating and drinking. As David said, it's not considered suicide. It is legal in all the states of the Union. And it is the important thing is that this is a voluntary stopping of eating and drinking. I spoke with some hospice chaplains, and they said that it's really important to differentiate that from what happens at the very end of life when there is a natural loss of appetite as the body approaches death. That is not VSED. That is just part of the natural decline and process of dying. It's complicated, and I'm happy to say that in your resource packet, there are 2 resources that will elaborate on VSED. And in particular, there's one that is clinical advice for physicians as how to administer palliative care during VSED. Those are really important to read and absorb if someone is considering undergoing that process. So that's just a really short précis. We're now going to open up a Q&A session, and here's how I'd like to do it. I'd like to spend just a few minutes asking you to just think about what questions have come up, if you haven't already written them down, and ask you to put them into the chat that goes to everyone. And Toby is going to organize the questions and offer them to whomever they're best directed. So go ahead and start entering your questions, and in a couple of minutes, Toby will start posing those questions.
Christina asks about what happens with dementia and Alzheimer's and what are the rights of someone to end their life sooner. First of all, that's a legal question, and the answer to that question varies state to state. But what you should know is that VSED is always an option, which you can undertake any time in your life that you choose to do. And there are other ways that you can end your life sooner using medications. There is an organization called the Socrates Society that helps people do that. That, however, involves suicide, and you need to make sure if you're going to go that route that nobody intervenes while you're in the process of that. Anybody, anytime, can voluntarily stop eating and drinking. So there is no legal definition that's required for that. That is an individual choice. I once was dealing with a person with cerebral palsy who could have lived for a very long time, but didn't want to live like that and elected VSED. That person, even in the most liberal states in the United States, would not have qualified for assisted death, but chose to go it on her own.
Are you able to read the questions, David? There's a question I had which has to do with updating documents. What I imagined I wanted at 60 is now different than at 70. So just any thoughts about that?
I recommend to everyone that they redo their end-of-life documents every 5 years, because how a 30-year-old perceives it is very different from a 60-year-old, and a 75-year-old may have very different views than a 65-year-old. It's natural, and I think pretty much inevitable, that your views will change. And so I strongly recommend reviewing your documents every 5 years. And if you replace any of them, which is an excellent thing to do, you just have to make sure that it's witnessed, and I suggest you attach a note saying that the early document is intended to be void. As to whether these documents are followed, one reason to write a values statement that accompanies your document is because that tends to improve the likelihood that it will be observed. My friend Paul Wolpe, who's an ethicist at Emory, did a study and discovered that the inclusion of that kind of value statement substantially increases the likelihood it will be followed. When is it not followed? The two really common circumstances are when those documents don't follow you to the hospital. You need to make sure that people who are responsible have copies of the documents. If you know what hospital you're going to in advance, you can also submit the documents to the hospital so they're in your file. That's one. The second commonest reason why these documents are sometimes overruled is when someone in your extended family goes and says, no, don't follow that document, preserve their life at all costs. Not infrequently, that is either an Orthodox relative or someone who has not been around and been taking care of you and therefore not understanding your situation very well. My best advice about that is make sure that you've got a DPAC you trust, who's local, who can get to the hospital and help deal with those people. It's also, if you have a rabbi, make sure the rabbi understands your wishes and make sure that his or her availability and how to reach them is also in your records. Is there an absolute guarantee that your wishes will be followed? I wish there were, but there isn't unless there's a post, because a post has much more power actually than an advance directive does. A post is legally binding on medical care people. Keep in mind that the big issue for hospitals is that they don't want to be sued for malpractice, and it's easier not to be sued if they're preserving life rather than following your wishes than the reverse.
You may have answered this where the VSED, the DPAC, and the advanced directives, how they overlap or what's the difference. Is that something that's in the packets that would be help to explain those?
The purpose of a DPAC is to ensure that there is somebody who can make decisions when you are unable to make your own. You might not be able to make your own because of injury, because of sedatives, because of a coma, and then your DPAC has a very critical role to play. That's exactly how I get calls in the middle of the night. The advance directive may include the DPAC form. It depends on which form of advance directive that you use. The DPAC form is really easy to get hold of if you don't have an advance directive form that includes it. But in any case, you need to fill out that advance directive form first, because no DPAC person is going to do an adequate job following your wishes if you haven't gone through that with them.
Let me just jump in here to say that in the materials we put out, we didn't use the term DPAC, we used power of attorney, POA. So they're one and the same. It's just different terminology.
We do have a hand raised for Miriam.
I'd like to say something. I am a retired estates planning attorney. I've retired about 4 years ago. I haven't kept up with current events, but I had personal experience when my husband was in the hospital and dying. His roommate was a man who could not speak. He was very agreeable. His son had a power of attorney and was not there all the time, but he had made known to the medical personnel and had put in the file of his father his power of attorney. They didn't listen to him. And he was a very able advocate. You need a powerful advocate to carry your wishes out. And you need to be present at critical times, because the medical personnel would come in and say to this roommate of my husband, we're going to do XYZ. And the man would smile and nod and go along with it. And then the son would come in and find out that a procedure that he had not okayed had been done because his father smiled and nodded and went along with it. So it's really critical to alert everyone involved in the medical team that you are the person who has the authority, and they still don't listen.
One thing that helps in my experience is making sure, if you're the DPAC, that you talk to each of the nurses on duty, which means you need to talk to all 3 shifts of nurses, and also talk to the doctor, which helps. But in the end, what Miriam is describing does sometimes happen. And the only way you can guard against it is having someone there 24/7.
And I also always told my clients, print all of your documents on neon colored paper and bring them to the doctor, to the hospital. When I had surgery, I had a note pinned to my gown indicating which leg or which limb was going to be operated on, and the pre-op people were hysterical, but I wasn't taking any chances. But it sounds laughable, but you just don't know. You have to be very careful.
And one of the places where this often goes awry is when someone is in a nursing home and gets transferred to the hospital in an emergency. Very often the nursing home does not transport the documents the way they should. And therefore, anyone who cares about the patient should make sure those documents are filed at the hospital that the nursing home uses, even if there's no reason to anticipate that person needing to go to the hospital.
File should go with the person all the time.
Yes, but the nursing homes don't necessarily do it.
They're overwhelmed.
Yeah, so make sure that you've got copies of the forms already in the hospital records.
So do we have time for one more question? We have one more hand up. Meryl?
This isn't a question, this is a comment to the just previous discussion. The person who gave consent in the bed is allowed to give consent over his durable power of attorney if he is not legally labeled on compos mentis. So even though he has a durable power of attorney decision maker, and even if he has a living will, he at any moment can okay or not okay procedures. So I don't consider that not following the procedure unless the man was known to not be able to make his own decisions.
Which leads us to the recommendation that if someone is not going to be able to handle that well, that you get a legal ruling that they can't make decisions for themselves.
It can be really painful in the family.
It has to be negotiated.
David, when you say get a legal ruling, what is the process for that?
Guardianship.
Guardianship requires a court order normally. So yeah, you get an attorney and you go to court. In a situation like the person in a hospital bed, it's not so hard to do that. You can also get a temporary form of guardianship that's limited to while the person's in the hospital.
We have a little more time if anyone wants to either raise their electronic hand or put a question into the general chat to everyone.
There was a response to how to label the side of the body that you want to is actually write it on your body itself.
I recently had eye surgery and the instructions were written on my forehead. So that they did the correct eye as for the procedure.
And Phyllis notes that people can be of sound mind some of the time and other times not so much.
And that's particularly true if they've had sedation of any sort.
Can I add a comment about hospice? Okay, once you go on hospice, it's not necessarily a final thing. You're also allowed to come off hospice if you change your mind about any particular thing. And also, it's possible to go back on hospice after a critical emergency. However, if you're in a nursing home situation, which is where I work, you're probably not going to be allowed to bounce back and forth many times. So you would have to use that judiciously.
Well, can you just introduce yourself and your expertise?
Oh, sure. I'm Rabbi Merrill Crean, and I have a 30-year career in long-term care, which has involved hospice as well. I've worked for the last 25 years at the same location in a full spectrum retirement community, from independent living through full care.
Can I add a comment? I work with the deaf, and so if you have a person in the hospital with a hearing loss who's dependent on hearing aids to be able to hear, please have a sign over their bed that says person cannot hear you. Please make sure they have their hearing aids in or write to them. Otherwise, a lot of times people are considered to be incompetent, but they are not.
Thank you. All right, I think we'll take our 5-minute stretch break, bio break. Please come back at 11:10. So David is going to start with a personal story. Take it away.
So in addition to dealing with these matters from the point of view of bioethics, Jewish bioethics, I've also had a more direct story. My father had terminal cancer. In his last days of life, he lost consciousness, but continued to writhe in pain. And I said to the palliative care physician, you should be increasing his dose of morphine. And the palliative care physician said, oh, I can't give him any more without risking his earlier death. And I said, that's okay, administer more. And the palliative care physician refused, and he writhed in pain for another day and a half before he finally died. In my opinion, there was really no excuse for that palliative care physician's approach. Basically, it came out of his worrying about being sued. But I should note that in the leading person in this area in the conservative movement is Rabbi Elliot Dorff. And Dorff makes the point, I think, completely rightly, that increasing pain meds in order to provide pain relief, even if it results in death, is not a form of physician-assisted death. It is merely a form of pain relief. And I dearly wish that had happened for my dad. Sitting there for hours and watching someone suffer is extraordinarily painful. And that's one of the reasons why I've taken the position on physician-assisted suicide death that I have. Rivkah?
Yeah, thank you. Okay, so I am going to start out with some basic information about MAID, medical aid in dying, what it is and where it's legal. And then David will discuss some of the ethical dilemmas around MAID. We'll follow that with a short clip about the MAID experience in Oregon. And then we'll again open up for a Q&A session. So, what exactly is medical aid in dying? So I want to start by clarifying the difference between medical aid in dying and what is called active euthanasia. I've often heard people say, I wish we treated people who are suffering at the end of life as kindly as we treat our pets. I remember when a home visit vet came to end my tabby cat's suffering, and using a shot for general anesthesia and then an injection to stop her heart, it was very quick and painless. That is active euthanasia, when a doctor, in this case a vet, actively ends the life. It's the only option with animals because obviously they can't choose and they can't self-administer drugs. However, the federal government and all 50 states prohibit active human euthanasia under general homicide laws. Basically, you can't ask a doctor to kill you or anyone else for that matter. David already mentioned the withdrawal of treatment or life-sustaining machinery, and that is sometimes called passive euthanasia, the whole other category. The current option for people in just 11 states and DC, and possibly soon in Illinois and New York, is medical aid in dying, MAID, and it's generally highly restricted. This is why it is a legal form of suicide, because it is so highly restricted. The New York State Bar Association defined medical aid in dying as when a terminally ill, mentally competent, adult patient who is likely to die within 6 months takes a prescribed medication which must be self-administered to end suffering and achieve a peaceful death. So you've got a number of requirements there: terminally ill, mentally competent, adult, likely to die within 6 months, takes prescribed medications, and they must be self-administered with the objective of ending suffering and achieving a peaceful death. There are additional requirements in states' fine points, such as residency requirements, waiting periods, and how many doctors must sign off on it. But regardless, as you can tell from this basic definition, many people who could benefit from assistance to end their suffering, even in a state that permits it, cannot, because they lack the mental or physical agency. And note that by definition, one's medical POA cannot request it on their behalf, no matter what one requests ahead of time in one's advance directive. Most states effectively prohibit medical aid in dying, and Pennsylvania is one of them. And this is unlikely to change anytime soon due to the influence of Republican culture wars going on and the influence of the Catholic bishops in Harrisburg. In fact, assisting a suicide in any form under criminal statute 2505 is a second-degree felony if suicide or attempted suicide results. So, bad news for Pennsylvania residents who want to avail themselves of it. So where could you go if you wanted to obtain MAID? Well, there's one state included in the above count, and that is Montana, is an outlier. And it permits medical aid in dying by way of a state Supreme Court case in 2009. And so far, their legislature has provided no legal regulations. It really is the Wild West out there. New Jersey is the state closest to us that permits medical aid in dying. However, it has a residency requirement and a 15-day waiting period from the first request. Only Vermont and Oregon, and of course Montana, have no residency requirements. Your resource packet includes links to information about procedures for Vermont non-residents and a link to information about other countries, including Switzerland and the Benelux countries. Canada, incidentally, has very liberal laws in this regard, but they don't apply to visitors. The government website that I consulted said specifically that visitors cannot avail themselves of MAID in Canada. So meanwhile, in Pennsylvania, the closest you can legally come to MAID is the voluntary stopping of eating and drinking under medical supervision. And again, I refer you to the links in the very detailed information in your packet about VSED. That said, David, some ethical dilemmas in MAID.
Yeah, there are a few that are pretty common. One is when a family is split about it. There have been any number of circumstances where the Orthodox members of a family have tried to intervene to stop MAID. And that's an issue that can only be resolved by blocking their presence or by much advanced discussion about their not having the right to intervene. But if there are people who are clinging to the doctrine of saving a life, trumping everything, sometimes that gets really sticky, and then a lockout is the only way you can accomplish it. Two other problems that arise. MAID should only take place when the patient is free from duress. And there are a couple of kinds of duress that one needs to look out for. One is when the family or some other agent is pressing for MAID because they want to preserve the family money for others after the death. That clearly does not justify MAID, and any financial pressure needs to be removed in order to make a reasonable decision to utilize MAID. Third issue is depression. It's not that infrequent that someone with really serious depression wants to end their life to escape that depression. For MAID to be justified, every effort to resolve that depression needs to be undertaken. And that might mean figuring out how to reduce the person's social isolation. It might mean medication. It might mean verbal therapy. All efforts to resolve depression should be undertaken before the MAID option. And people who are near someone with depression should do everything in their power to get that person into appropriate treatment long before MAID comes under discussion. A fourth one, and I find this one particularly abhorrent, I have to acknowledge, is when people want MAID for the patient because it would be a lot more convenient for them not to have to wait around for the death. That is not a legitimate reason for MAID, and family pressure about convenience or finances really is beyond the pale, and a good physician will try to help shield from that But in any case, anyone that you know who might consider MAID needs to understand that they have no obligation to give in to such pressure and should really avoid it. One other issue that does surface sometimes is issues around social and class inequities. It tends to be the case that upper middle class and wealthy people have much more access to MAID because they have the right access to physicians, they have the right access to supportive care, and so on. We should be working to ensure that people who can't afford a lot of medical care have the same access to MAID. It tends to not come up in hospitals for people who are on Medicaid. It tends not to come up in hospitals without the family bringing up the discussion. And certainly in terms of financial differences, going out of state, or better yet, going to Switzerland, becomes a huge financial burden as well. So that's one of the issues. And another one is around issues of color. Many of you are probably familiar with the Tuskegee experiments and with other experiments on prisoners. The results of those is that many people in the Black community have come to be legitimately suspicious of medical personnel, and particularly so if the issue of death comes up. So in those cases, it's really important to find allies from within the Black community who can help that person navigate the choice very well. And of course, one of the other issues is that often people realize they would want MAID later in their treatment, but find that either they can't self-administer at that point or they can't pass the lucidity test. And at this point, there's not a lot that we have available to us to deal with that. And the result is that some people end up saving up medications and ending their lives without the benefit of medical support in order to ensure that they will be able to end their life in a dignified way. And ethically speaking, there's no distinction between MAID and self-administered suicide. And insofar as we think about healing and about dignity, suicide sometimes is a completely acceptable moral choice. And there are things we can do to be those we leave behind to cushion the blow. And I do strongly advise that, but that's a different kind of moral issue from whether suicide itself can be legitimate Jewish choice.
Now, the only thing I want to add is to that, David, is that you emphasize that suicide can be an ethical Jewish choice. However, because of the legal structure, certainly in Pennsylvania, assisting someone in that suicide is not an okay choice. There was a case a few years ago of a woman whose father was approaching death. She was a nurse, actually, and on her way out of the home, she handed him some morphine, I believe it was. He actually used it to commit suicide, and she was arrested and jailed for having been an accessory. If you're planning such a thing, don't involve others. Thank you, David. I'm now going to introduce the film that is called How to Die in Oregon. It was filmed some time ago after Oregon became the first state in the union to legalize MAID. And the film actually opens with a scene that the sound quality is not great, and it can be very difficult for some to watch. So I'm just going to describe it to you before I start the film. So before the slide title, the film opens with the final minutes of a man who is preparing to drink the barbiturate that will first put him in a coma and then stop his breathing. He's surrounded by his family. A volunteer guides him through the brief final MAID process, which is affirming his understanding of what is about to happen and his choice of what is happening. He then has the opportunity to offer last words to his family. He takes the glass and drinks the liquid. It's about 6 ounces, and he has chosen a cream soda chaser. He then lies down and briefly sings a song as he waits for the coma to set in. His last words are thanks to his family, to the voters of Oregon for making this possible, and to his medical team. The remainder of this clip, which we'll show now, follows Sue Porter, who is the volunteer with the Oregon nonprofit Compassion and Choices, through clear-eyed conversations with several patients in different situations and with one of their doctors. The film clip that I'm going to share takes about 17 minutes, so that would make it about 10 of noon that we'll pick up with the final Q&A session.
In my time of dying, I don't want you to moan. All I want for you to do is bring my body home. Well, 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 so I can die easy. Well, 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 so I can die.
Gordon Green, the doctor dropped a prescription off this morning for me.
Gordon Green?
Yes.
Jesus God.
I have Blue Cross Regency First Choice 65.
Do you have your card with you?
You bet. I didn't think this would be covered.
Alrighty. Your total search comes to $89.52. There's your merchandise. There's your card back. Thank you very much.
Thank you.
And have a very good day.
I'm going to. Every day is a good one.
How you doing?
Fine.
Bring me a hurry home. So I can die easy.
Where do you want this?
I'll take it. I gotta find out if I have to refrigerate it or not. Apparently not. You didn't say nothing. This here is the final medicine I'll have to take. Hi, Sue. This is Gordon. I know it's Sunday, and I just leave a message for you. I picked up the medication today at Bimart, so we have it here in the house. Have a good day and a good weekend. Goodbye.
Well, 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 so I can die easy.
Oh, boy.
Well, well, so I can die.
Glad that's done.
Yes. That was easier than I thought.
Yeah.
Jesus gonna make me die in bed.
Hi, Sue. This is
Jesus
Gordon.
gonna
I know
make
it's Sunday, and I just leave a message for you.
I feel very privileged to be on the forefront of such a vital medical, social, and political movement. What I think about when I'm meeting someone for the first time is there's always some anxiety, and I think that anxiety is productive. I would never want to become laissez-faire about this whole process. And what I think about is, are they going to understand exactly what it is they're pursuing and what the process is? And also, what's always foremost on my mind is that they know that they are in charge, that they're the boss. Hi, Elizabeth. Oh, she's not. Okay, okay. Hi, Mrs. Lickey. I'm Sue Porter with Compassion. We've talked on the phone a few times regarding wanting to make your own end-of-life choices. and getting a medication to maybe end your life if that's what you choose to do. And I'm here to go.
Enter life. I'm in life. I've already entered life. I want to exit life.
These people have lost so much control, and they'll tell us repeatedly that they want the medication for control. Whether they take the medication or whether they don't, at least they can make that decision.
Unfortunately, I was diagnosed with ALS about a year ago, and I just received my 6 months diagnosis to live. I still can walk with difficulty, but that's when that ends, then I'm gonna be making that decision.
So, Gail, how do you react to everything that Peter is saying? And
this is the way he's thought for a long time. It's just going to be hard. We've been together for a long time. And he's wonderful even now. He helps me in many ways.
This is the request for a medication to end my life in a humane and dignified manner. You will sign this, Peter, and then you will have 2 witnesses sign it. And what they say is that you're of sound mind, and you might find that the time that is in your mind of when you can't walk anymore might change.
Yep.
That changes all the time with people, and there's nothing set
Right.
in stone.
I understand that. Appreciate it.
Okay.
Everything's ready, I think.
Okay.
There's a very fine line here of never ever wanting them to think that we are selling a process. We're not. What we're doing is offering choice. And so as I communicate with people and as I contact them, I really always want to be sensitive to that principle. Make sure and request Seconal. You want the one that costs less?
I don't know. Which one is it that you just drink?
That's Nebutal. Actually, I see it in these notes.
One.
Yeah, right here. It's Nebutal. Mrs. Wakefield, we cannot quote these prices for sure.
Yeah.
But Nebutal is well over $1,000. Seconal is $130. I go into these situations with a certain amount of pragmatism because I have to. If it were all emotional, I couldn't do this work.
Hi, Sue.
Hello, Donna. How are you?
Pretty good. How are you doing?
Just fine, thank you. Good to see you.
Good to see you too.
Hi, Gordon.
Hi, Sue. You're looking great.
Thank you. Donna or Gordon, do you have the medication?
Yes, down it's in the lower drawer, way in the back, right-hand side. Yeah, we picked it up and no problems.
Great.
Yeah, everything went well. And we hope it stays right there. But if I'm in that bed and I'm racked up with a stroke or something like that's when I want it. I'm not going to lay there and be a burden to her. I saw my dad 12 years with a stroke and one whole side was gone. He says it's like living in a barrel. See out, hear everything, physically couldn't do anything. And he kept saying, I just want out. And my mom ended up the same way. She wanted out. And I didn't figure why they want to do that, but I understand now.
Yeah.
You can only handle about so much garbage, and then you've had it. But I'll handle it until something like that happens.
Okay. So you got Seconal. There's 3 different medications here. I know we've talked about this before. We represent choice. We don't represent death. If you were ever going to make the choice to take this medication, this is how it would work. I'd ask you 2 questions. First of all, you have the right to change your mind. And secondly, I would ask you to explain to me what this medication is going to do. And You have the choice of doing this any way you want. You could have just Donna here. You could have friends here.
Just this one.
You can always change your mind. It's totally up to you. And then what this is Seconal. And Seconal, there's 100 capsules in here. And you don't take 100 capsules.
It's going to take me all day.
Yeah, exactly.
I die from exhaustion.
Yeah. What I would do is open them up and empty the powder. And then add 6 ounces of room temperature water.
I'd have a good cold beer to wash that down.
Yeah, you can have whatever you want.
Yeah.
This has to be consumed in about a minute or a minute and a half.
Oh, that's a piece of cake.
And normally people go into a coma, really, Gordon, within a few minutes.
Oh, the heart's so bad it wouldn't handle it.
Yeah.
If they should pop it right off the bat. I'm getting little episodes damn near every day.
You are.
So I don't think I'm going to need that, but I want to just go in there, lay down some night and go to sleep, and I'll wake up. That's the decent thing to do.
Mm-hmm.
So for once in my life, I'll be decent.
I'm feeling good. We can do this again. It's not the last one. I've forgotten how steep these hills are. Okay. Joey, I think this is... Actually, should we try and go to the top?
Good for it.
How's your knee?
On the way back. I'm fine.
Okay, you can carry me back.
We'll carry you.
I am feeling so good. I got a lot done this morning already. I went to Goodwill. Oh, which reminds me, I was going to invite people to shop my closet, but you guys can go first.
Talking about the day that we wanted an old.
You gotta touch the tree.
Chris said she wanted an old sweatshirt shirt of yours.
She did. She wants that green
I
hoodie.
thought that's a good idea, and then I thought, what do I want? And then I said, can I have the Volvo?
You may borrow it any time.
Go this way.
I think we can loop back down and do the... I'm good. Actually, if you want the Volvo, Stan will probably...
In November of '07, I had a terrible stomachache. It was pain that takes your breath away, which I never ever have. So I hied myself into the doctor a few weeks later. She ordered an ultrasound for me. And she got the results of the ultrasound and she called me into her office and then she burst into tears. And she said, you have a big mass on your liver.
Cody had a primary cancer of the liver that was roughly the size of a grapefruit. It was a type of cancer that we don't have any good chemotherapy agents for, any good radiation agents for. So it's the type of cancer that is treated surgically or we don't have a lot of effective options for. We had the one shot of taking it all out and hoping that was going to be enough for her.
I had the first surgery and it seemed to have gone all right, and then there were complications and I ended up in the ICU in the hospital for 50 days. I was in a coma for quite a while. And all of a sudden I opened my eyes really wide and said, what is happening to me?
The night before her second procedure, she was supposed to be taking pain medication, pills, and she was throwing up and couldn't keep the pills down. So the pain medication was wearing off, and she said that, I don't ever want another night like that.
If she had died in the hospital, it really would have felt like she was pulled out of our hands. Because then you're still fighting to keep her. And that's what hospitals are about. It's about that fight to keep you alive.
I had to learn to walk again. I couldn't eat. I couldn't go to the bathroom by myself. I couldn't shower by myself. I fell and I couldn't get up. It took 6 months before I was able to take care of myself again.
We were actually all starting to feel that maybe we'd dodged the bullet. And then the radiologist said there was something that looked a little funny on the CAT scan. I saw it and had to give her that call saying that there was obvious cancer recurrence. The cancer was back and we didn't have any really good options for her.
The outcomes for this disease have not changed in 30 years. If you can cut it out, great. If you miss any cancer, it'll be back, and it'll be more aggressive.
She said, if this comes back, I know that I don't have any good treatment options, and I want to be able to have that in reserve, the death with dignity law. It shocked me thinking about it in the intellectual realm of this is a law that supports my values versus I'm actually going to take a pen and write a prescription for something that will end someone's life. What really settled the decision for me was talking to my sister, who's a breast cancer survivor, and I talked to her about how much I really liked this woman and how much we had been through together. We had slogged through a year together in a very close, very intimate relationship as patient and doctor, and how fond of her I was and fond of her family I was. And my sister just said, of course you're going to do it. You have to help her. You're her doctor. And that's really the deciding point for me.
If I had an option, I would prefer not to die, thank you very much. But given that I know I'm going to die, does an extra 3 months if of fluid leaking through my pores sound that great? No. Rather go when I'm still feeling okay and when I can still communicate with my family.
She cares a lot about her kids. She is also very dignified. I think when she looks sick, for her that's very difficult because she wants to present herself as being healthy.
I grew up in the country. We put our dogs and our horses down. We didn't let animals suffer.
I think Cody taught me that first do no harm is going to be different for every patient. Harm for her would have meant taking away the control and saying, no, you've got to do this the way your body decides as opposed to the way you as the person decides.
Okay. So maybe deep breath, deep exhale is warranted. And so now we'll open up the last section to Q&A about MAID. And if you have residual questions from the first half, please feel free to insert them as well. Again, if you can put them in the chat, that may be helpful. If you're unable to do that, please feel free to raise your electronic hand so we'll see you.
David, I have a question. This is Toby here. The people in this film all were very supportive and had accepted this decision, it seemed. The doctor was the only one who was questioning. Are there ways to support or to bring this information to people who, in the family and system, who are not supportive, who might have trouble with this?
First off, if the person considering MAID is strong enough, both emotionally and physically, I encourage them to have conversations about it as far in advance as possible, starting, of course, with their immediate family, and then working their way outward to close friends and extended family. Those conversations are often pretty weepy, and they're not easy, but it helps everybody a lot to know what's coming. It makes the death much easier to take when people have had a chance to hear from the person who is going to die. And if there's someone who's really strongly resistant after more than one conversation, you should make sure that they're not present when you're ready to actually take the medication. Of course, if you're traveling to a different place to do it, then it's less likely you're going to have very many people around you. But you want people in the room with you who have genuinely accepted that this is your choice and they're supporting it because it's your choice. They should not be supporting it because it's better for them. The real question is what's better for the patient. And occasionally you do have people who just can't accept it, and then you just don't want them there because they can disrupt your last words and your last chance to say goodbye, your last chance to tell people you love them. I would love to see a MAID law in Pennsylvania. There's absolutely no sign that's going to happen. It's not that it's never been proposed, but there's a huge amount of resistance to it. It's unlikely that we're going to have the advantage of having it available here. About the medication that you take, exactly which form of the medication is up to the physician and you. There's a form of the medication that comes already mixed and drinkable. It costs a little more. It's certainly preferable. In Switzerland, you actually check into a place that has the medication already for you. The form of medication used is shifted over time, and some of it is actually, depending on where you're doing it and where it's legal, actually covered by your insurance. Given that insurance companies have as their motivation to some extent to save money, it's actually a bargain for them when someone chooses that instead of the incredibly slow, ugly, expensive way to die in the traditional form. The reason why that had to be crushed in the video was because they chose the least expensive form, and I certainly don't advise that unless you have no choice. Any other questions or comments? David?
The whole thing is very touching, very moving. I notice I felt most troubled by the last woman who was going on a hike and had this liver cancer that was going to kill her within some number of months. And it raised for me the question of someone who's having positive life experiences like that. What's the boundary about when is it ethical to choose for yourself or to support someone else in ending their life in anticipation of future suffering?
The standard that I would invoke is what's in the person's best interest as they determine it. In the case of the woman in that video, she was preparing her friends for her departure, and I don't believe that she went ahead with it until she was experiencing serious pain that medication that left her fully conscious wouldn't relieve. But what you see there and what's important there is she's helping her friends and relatives to be ready for her departure. And I don't think she actually ended her life for some time after that. The open discussion about what's going to happen to your things is actually a relief very often for the person who's dying because they feel they've made their best possible arrangements. Things have been done the way they want them done, or will be done after their death the way they want them done. And I think the two commonest categories of people who elect MAID are people with cancer or other painful terminal illnesses, or people who are recognizing that due to dementia of one sort or another, they're losing their capacity to think and choose. The folks who are on the pain spectrum have it easier to figure out when they want to die than folks on the Alzheimer's spectrum. But one of the things that drives people to Switzerland is they are more willing to let someone with significant mental impairment undergo MAID there than any of the laws in the United States permit.
Rose, did you want to say something?
Can you hear me? All right. Her last comments, let my body decide or let me, the person, decide. So what if I also want God from the religious standpoint to help me decide? Yes, that's my question.
I think that one question is, at what point do you feel like you cannot sustain your dignity? Whether that's because of lost control of your body or deterioration of mind. And the second one I've said before is what's in your best interest? At what point does the pain or suffering trump what you gain from life? And it's certainly been my experience that varies hugely person to person. Some people would say just being able to be around my family is so important to me, I'm willing to endure virtually any level of pain in order for that to be the case. I can tell you from members of my own family that not everybody feels that way. Some people feel like I just don't want any serious level of pain, and anything that causes me so much pain that the medication would cause me to lose my full awareness, that's the time when I would want to elect MAID. And neither of those choices is unethical, and it's deeply personal.
David, I had a question. Do you know what the training was for the woman in the movie, The Woman from Compassion? I asked that because it seems like MAID isn't available in Pennsylvania, but helping people make decisions is, or helping people think through whatever they're going through.
I don't know the answer to that. I do know that hospice chaplains in particular have the training and the know-how to have those discussions with patients. So that's one place to go. Some regular hospital chaplains can do that. There are some rabbis who have that background. The key thing, though, is you want to make sure that the person that you're having that discussion with, A, is open to really hearing where you're at, and B, is not some form of a right to lifer. I've had Orthodox rabbis say to me privately, much as I would like to follow the position that you've taken publicly, I don't even dare do it privately because I could lose my pulpit. So think and make sure that the place you're going to get coaching might be a good social worker or a good therapist, that they're open to considering a MAID type, and if they're not the right person to have the discussion with. No therapist that I know and no chaplain that I know of has ever urged somebody toward MAID. That's not their role. Their role is to help them think it through, and I've never encountered someone who overreached in that way.
David, I'm hearing more this term about death doulas, end-of-life doulas. Can you speak to that at all?
Sure. Y'all are mostly familiar with the doulas who deal with birth. The job of a doula is to ease people through a process. A doula is usually skilled, as is a hospice chaplain, at dealing with the spiritual issues and the emotional issues that accompany getting ready to cross the threshold. And they can often be supportive, and very often doulas, in my experience, also help family members who are going through this with the dying person. As in choosing a physician or a home healthcare person, you don't want to make that decision in the last possible moment. It's helpful to interview a few doulas and decide who you're most comfortable with before you make a selection. But in my experience, they do really good work, and I've never had anybody who talked about having seen a doula involved in the process who thought they were anything but helpful. Sounds like we've exhausted. Oh, Sheila.
Is it possible for us to see the rest of that movie?
Yes, in your packet, there is a link to the movie on Tubi. Tubi is a free streaming site, and you can watch it at your leisure at any time, as many times as you like. It's under the category of films, and I will mention that there is a second film there. It's a little problematic getting a hold of it. It's a film called When My Time Comes, done by Diane Rehm after her husband died. And she spent some time interviewing people of all positions on MAID, many different faith traditions and the like, to talk about whether or not it's something that should be legalized. She wasn't approaching it from should an individual do it, but from the question of a societal decision. It's no longer available on PBS, but there's information in your packet about how to access trailers and discussions about the film, and also the book that she wrote based on the film. So there's some additional resources for you there.
I just want to add one more thing to what I had said earlier about people with hearing loss. Also, many of us, like myself, who wear glasses, it's really important that there should be some type of sign saying person needs their glasses, because all of us who wear glasses have from time to time said, oh, let me put my glasses on. I hear better with my glasses on. When giving information to people, especially in nursing homes where my grandmother's glasses were always going missing, it's important to make sure that people do at least the minimum to help the person be able to function to their maximum.
Miriam, your hand's up.
Yes. You had mentioned the relative ease of assisted suicide in Switzerland. I understand that Belgium and Netherlands also have similar MAID laws or provisions.
They're similar but not the same. If you decide that medical tourism is an option, you should really get exact guidance. And why am I not giving it now? Because these laws keep changing. The Netherlands has the highest rate of assisted death of anywhere in the world. In the Netherlands, you can invoke it if you're living there just by saying you're tired of living. That's considered an adequate psychiatric election there. But there's also been increasing concern that the percentage of the population using MAID has gone up every year. And so there's some talk of tightening the legislation. I don't know if that talk will lead anywhere, but I do know from having interacted particularly with the Ontario law that's now in its third iteration, and there have been significant changes in Oregon over time as well, that you can't assume that what you hear now about the law is going to be what is there in even a few months. It's worthwhile checking if you get to that stage. And the law in Belgium is not exactly the same as the law in Holland, even though it's modeled on that law. And it's modeled on the earlier form of the law, not the current form of the law. This is something where I don't even claim to keep up, because if I go somewhere for a consultation, I always get a lawyer to brief me first, because things change too fast for you to rely on what I say today at all. Not unless you know someone who's really in immediate need. A lot of these countries actually are explicit and up to date on their websites. So you can Google to find out in each case pretty easily. Once you've picked a country, you then need to be in touch with a facility that facilitates this kind of thing and make sure that they're willing to take you. And usually there's a medical screening panel you have to go through. The screening is different for Switzerland, which doesn't require a mentally competent patient as long as the paperwork is all correct. So in any case, you just really need to make sure that you follow the process for that particular location. And Ontario, where I'm familiar with because I've done some work there, has really good law, but it's not accessible to visitors.
No. Also seem important to make a plan for how to get the body back to wherever you came from for burial.
Assuming you want burial.
Or cremation, whatever you're doing.
You
plan for what you're going to do with the body, the remains.
And you need a plan for what you're going to do with your estate. And generally, people who travel to have this done have either a relative or a friend come with them who knows exactly what arrangements need to be made to follow up. You really don't want to take that trip to Switzerland by yourself.
I'm just going to add once again that in your packet, which came as an attachment to the announcement that came last night, there is a link to a UK website where they are trying to get MAID legal, and they are tracking all of the European and other countries and what the situation is there. So as long as they keep up that website, that's a kind of centralized place to start. And it includes other countries such as Australia, New Zealand, even some countries in South America. So you can check the world, get a bird's eye view on the world through that particular website that's there in the packet.
I don't see any more hands or comments, Rivkah, so I think we're ready to move on.
Good, thank you. I'm just going to say that I am going to be sending out probably this evening or sometime the next couple of days a survey from SurveyMonkey to everyone who signed up for this program, because first of all, we would like your feedback and any suggestions you have for how we might improve this or similar programs in the future. The program committee is considering a number of different kinds of programming going forth in the coming year, and we'd like your input for that. And we'd like to know, since Shtetl 2.0 is a village model of neighbors helping neighbors, we'd like to know what skills and talents and experience you have to contribute into the mix, and a number of other questions. So really appreciate if you would respond to that. It should take about 5 minutes to fill out, a lot of check boxes. You don't have to write any long essays. So that's pretty much it. Thank you so much for being part of this and contributing your presence and your questions. Really appreciate. So David is going to close with a kavanah for going forward.
Before David speaks, maybe we can all give a hand of gratitude. Thank you to Rivkah for coordinating this and orchestrating, for Sherry, and for David, of course, for his sharing his extraordinary expertise and experience in this field. Thank you so much. It's all yours, David.
What we hope for is rich and meaningful and healthy lives. And at each stage of our lives, we can ask, how can I be of service to others? How do I take care of myself? How do I make sure that my connections to others are as rich and meaningful as they possibly can be? What we want as we go through our later years is to live in a way that leaves as little regret behind as we possibly can. So I pray for each of us that we fill our days with gratitude, with wonder, and with a sense that no one is too old to contribute back to our world. And when it comes time to consider our end, may we realize that life is a gift that is not a permanent gift. May we go toward our end with gratitude and graciousness.
Amen.
Amen.